As a brain doctor, let me be painfully clear from the very first sentence. Most people who go to bed tonight will put their head on the pillow in a way that quietly drives up nighttime blood pressure spikes, chokes their oxygen when they least notice, and sets off the very chain reactions that push a vulnerable brain toward stroke. That sounds dramatic, it should, because while daytime numbers and daytime habits get all the attention, the single most neglected risk window for your brain is the 6 to 8 hours after you close your eyes. The truth I want you to take away from this video is simple. The position you sleep in and the way your head and neck sit on that pillow can either protect your brain while you sleep or sabotage it. I'm going to walk you through exactly how this happens, why one common position is the worst choice if you're over 50 or have any vascular risk, and what you can do tonight to change it without turning your bedroom into a lab. Before we go further, a quick but important note. This video is for education. It is not personalized medical advice. Stroke risk is influenced by many things you and I can't see through a screen. Your medications, your blood pressure pattern, your heart rhythm, your anatomy, your weight, your airway, your past medical history. If anything I say fits uncomfortably well with your symptoms, use that discomfort as the nudge to talk to your own clinician. Don't self-diagnose, don't self-treat, and don't stop prescribed therapies without guidance. This is how we keep you safe while we get you stronger. Now, when we talk about stroke, we're really talking about blood and oxygen supply to brain tissue. Your brain is greedy in a good way. It needs steady oxygen, steady blood flow, and steady electrical calm to do the quiet maintenance work of the night. The moment you fall asleep, your brain is supposed to slide into a rhythm of clearing waste, consolidating memory, and recalibrating hormones that control blood pressure and inflammation. If anything interrupts that rhythm, oxygen dips, surges of stress hormones, spikes in nighttime blood pressure, heart rhythm disturbances, you don't feel those changes like a sharp pain. They happen in silence. And yet, they're the changes that, over weeks and months, stiffen vessels, injure the inner lining of arteries, and make small clots more likely to form or lodge where they absolutely don't belong. Here's the part that still shocks people. One of the strongest drivers of those overnight insults is not a pill or a food. It's a position. Lying flat on your back with your head tipped back or tucked wrong on a pillow narrows the upper airway in many adults, especially as we get older, gain even a small amount of neck soft tissue, or take medications that relax airway muscles. That narrowing doesn't have to close completely to cause trouble. Even partial collapse repeats hundreds of times a night as you drift through sleep stages, each time dropping your oxygen, jolting your nervous system, spiking your blood pressure, and yanking your heart rhythm around. We have robust evidence that obstructive sleep apnea, those recurrent airway collapses during sleep, is associated with higher stroke risk, independent of other risk factors. In plain English, even when you account for high blood pressure, diabetes, or cholesterol, untreated airway obstruction at night still correlates with more strokes. That is not a scare tactic. It's the data talking, and it's one reason I take sleep positions seriously in every patient with a brain to protect. But is the back sleeping position really that different? Yes, and here's why. The airway is a soft-walled tube wrapped in muscle. Gravity is not your friend when you lie on your back. Your tongue and soft palate drift backward, the space behind them shrinks, and the effort your body must make just to keep airflow going increases. Studies repeatedly show that many people have positional sleep apnea, worse on their back, better on their side. On the back, breathing pauses last longer and happen more frequently. On the side, the same airway behaves better. That difference in position doesn't just change how loudly you snore, it changes how low your oxygen falls, how often your brain is yanked out of deep sleep, and how violently your blood pressure surges to rescue you. Those surges are not benign. Over time, they bruise the inside of your blood vessels, the same way repeated tiny taps bruise a peach. Nighttime blood pressure deserves its own spotlight because too many people obsess over the numbers they see in the clinic and ignore the numbers they never measure. We know from cardiovascular research that the pattern of blood pressure while you sleep, particularly if it fails to dip or worse, rises at night, is strongly associated with future heart and brain events. Think about that. You could have reasonable daytime readings and still be a nighttime riser, silently damaging your brain's microvessels while you dream. What makes it rise? Oxygen dips from airway collapse are one driver. Pain, reflux, bathroom trips, and even certain late evening behaviors are others. It's not that one bad night dooms you, it's that repeated nights of elevated peaks and averages create a storm your neurons can't afford. Peak nighttime pressures above certain thresholds have been linked to higher stroke risk, and the riser pattern is a known red flag. If you add airway obstruction on your back to a body that's already salt-sensitive or alcohol-sensitive, you stack the deck. Let's address another silent culprit that gets dismissed as just heartburn: nighttime reflux. When you lie flat, gravity stops helping keep stomach contents where they belong. Acid creeping up the esophagus doesn't only burn. It triggers arousals, activates your stress responses, and can provoke micro-aspiration events that inflame lungs and disrupt oxygenation. The position you choose changes reflux dramatically. Supine, flat on your back, makes reflux episodes more frequent for many. Left side sleeping, by contrast, tends to reduce acid exposure time and helps the esophagus clear faster, while right side sleeping can worsen esophageal acid clearance for some. If you have reflux and you sleep on your back, you've effectively chosen a position that invites reflux to wake you, stress you, and indirectly jack up your nightly blood pressure and arrhythmia risk. That matters to your brain, even if the burn feels like a stomach problem. This is why I tell my patients that back sleeping with a neutral to low pillow is the stealthy brain-taxing position for a lot of older adults and anyone with airway vulnerability. It's not that your back is evil. It's that your back removes gravity's help, narrows your airway, encourages reflux, and makes your body fight for oxygen all night long. That fight injects bursts of adrenaline, constricts your blood vessels, and destroys the smooth, restorative sleep your brain needs to repair itself. Do that once, you feel groggy. Do it every night for months and years. You harden arteries, you strain the heart, you invite atrial fibrillation, the irregular rhythm that throws clots, and you raise your stroke risk even if your daytime looks normal. That is the real overnight risk hiding inside a simple habit. So what is the safer alternative? For many, it's side sleeping with smart support. Side sleeping helps keep the airway more open. If reflux is an issue, the left side often reduces acid exposure. And elevating the head of the bed, think of lifting the headboard a few inches or using a wedge that tilts your torso, not just stacking pillows under your neck, can meaningfully reduce both airway collapse and reflux. These are not exotic tricks. They are positional therapies that sleep specialists have used for years in positional sleep apnea, and while they don't replace CPAP for moderate to severe disease, they're low-risk steps that make real physiology better. The reason I emphasize head of bed elevation rather than pillow pile is alignment. Lifting the torso keeps the airway aligned and the diaphragm moving well. Jamming your chin down into a stack of pillows kinks the airway and is the opposite of what we want. Let me be concrete about what fixing your position actually looks like. If you currently fall asleep on your back because it's comfortable or it's simply a habit, start by shaping the bed so the side position is the path of least resistance. A medium firm pillow that supports your neck in a straight line with your spine, a small pillow or rolled towel placed along your back to make rolling flat less inviting, and a knee pillow to keep your hips aligned go a long way. Some people tape or sew a soft object into a pocket on the back of a pajama top, a classic tennis ball trick, so that rolling onto the back gently nudges them back to the side. If you have reflux, adopt the left side as your default and elevate the head of the bed by 6 to 8 inches, or use a foam wedge that lifts the chest and head together. If you have shoulder issues that make side sleeping painful, try a body pillow to distribute pressure so your top arm and leg are supported rather than sagging. And if you're still waking, choking, gasping with morning headaches, morning dry mouth, or daytime sleepiness, do not DIY get evaluated for sleep apnea because position alone may not be enough. Because I'm your brain doctor in this room, let me connect the dots from your pillow to your plaque. Recurrent oxygen dips, from even mild airway obstruction, tell your brain and blood vessels that a threat is present. Your sympathetic nervous system, the body's gas pedal, hits down. Vessels clamp, sugar rises, clotting pathways get a subtle push. Those spikes teach your vascular tree to be twitchy. Combine that with nighttime blood pressure that doesn't dip or worsens, and you have a recipe for small vessel disease, tiny cumulative injuries that we later see as white matter changes on MRI. Those changes are not cosmetic. They're correlated with gait slowing, weaker retention, and higher risk for both stroke and certain dementias. This is not to frighten you into insomnia. It's to remind you that small daily choices, position, timing of your last drink, how you support your neck, sum into very big differences in how your brain ages. Let's talk about alcohol and salt, because they quietly sabotage good sleep position. Alcohol is a muscle relaxant. A drink late in the evening makes airway collapse more likely, deepens the oxygen dips, and fragments the second half of the night when your brain most needs deep, restorative sleep. Salt sets the stage earlier. A salty dinner shifts fluid into your circulation, makes you retain water, and can raise nighttime blood pressure. For many older adults, the worst pattern I see is a late salty meal, plus an evening drink, plus back sleeping. That combination takes a vulnerable airway, lowers its tone, floods the system, and then asks the body to breathe smoothly through the night on its back. You can change that pattern in 1 week. Earlier dinner, lower sodium, no alcohol after the early evening, side sleeping with head of bed elevation, and you've pulled 3 levers at once: better airway, fewer reflux hits, and calmer nighttime blood pressure. That's how we chip away at stroke risk in the real world, by stacking small advantages. Many of you will ask, what about the left versus right side? If reflux is your main complaint, left side gives you an anatomic advantage. The stomach sits in a way that reduces acid flow into the esophagus, and studies show shorter acid exposure and faster clearance on that side. If you don't have reflux and you're otherwise healthy, either side can be helpful for airway compared with back sleeping. Some people with certain heart conditions feel palpitations more when lying on the left and prefer the right. That's fine. Comfort matters for adherence. The headline for the brain is not left or right, it's not flat on your back. If you're a stubborn back sleeper, elevate the head of your bed and keep your neck neutral so the airway stays open and the chin doesn't collapse space. Your goal is a position that your body can maintain for hours without inviting oxygen dips or reflux. What if you already have diagnosed sleep apnea? Then your first line is the therapy you were prescribed. CPAP and well-fitted oral appliances aren't optional decorations. They're brain-saving tools that keep your airway open so your oxygen remains stable and your blood pressure doesn't surge with every snore. The tragedy I see is people who kind of use CPAP, or who put it on at bedtime and rip it off at 2 a.m. when it feels annoying. That second half of the night is when your brain does housekeeping, memory consolidation, synaptic pruning, toxin clearance, and it's when apnea often worsens. If your mask leaks, if your settings feel wrong, if dryness wakes you, those are fixable problems, not reasons to give up. Position still matters with CPAP. Side sleeping and head of bed elevation can reduce the pressure needed and improve comfort. If you were told you have positional apnea, ask your sleep clinician about positional devices that keep you off your back. They won't replace CPAP in moderate to severe disease, but they can complement it or help in milder cases. The theme is the same: protect your airway, protect your brain. I want to address a less obvious group: people who wake to urinate multiple times. Nighttime bathroom trips fragment sleep, raise stress hormones, and yank blood pressure around. Sometimes the cause is simple: late fluids, caffeine, diuretics. Sometimes it's sleep apnea itself. The negative pressure swings during obstruction can trigger atrial stretch and a hormone response that increases nocturnal urine production. If you're up 2, 3, 4 times a night, fix position and fluids first, and if the problem persists, screen for apnea. Every interruption is a chance for your blood pressure to spike when you stand, for reflux to flare when you lie back down, and for that vulnerable airway to collapse again if you roll flat on your back in the dark. Protecting your brain means smoothing out the whole night. Here's a practical tonight plan I give my patients, because knowledge without a to-do list is a bedtime story. 3 hours before bed, finish your last meal. Keep it simple on salt, and if reflux ever visits you, avoid your personal triggers: chocolate, mint, spicy foods, heavy fats. 2 hours before bed, no alcohol. 90 minutes before bed, dim the environment and let devices go. Blue light and news alerts do not fix blood pressure. 1 hour before bed, take any prescribed nighttime medications exactly as directed. If you're on blood pressure medication, ask your clinician whether an evening dose makes sense for you. Nighttime control sometimes matters more than daytime. 30 minutes before bed, shape the bed for side sleeping. Neutral neck pillow, knee pillow, back bumper, rolled towel or positional device, and if reflux is a friend you'd like to lose, a wedge or blocks to elevate the head of the bed. At lights out, settle on your left if you're a refluxer, on either side if you're not, and treat the next 6 hours as non-negotiable brain therapy. What about mouth taping, special breathing hacks, or extreme pillows? Be careful. Mouth taping has risks if you have unrecognized apnea or nasal obstruction. I don't recommend it without a clinician who knows your airway. Nasal strips can help some people by lifting the valve area of the nose. They're safe to try. Cervical pillows that aggressively push your chin down are not your friend. They can narrow the airway. If a pillow encourages a neutral aligned neck and you wake without stiffness, you're on the right track. If a gadget claims to cure apnea without data, move on. Your brain doesn't need gimmicks. It needs oxygen stability, calm blood pressure, and sleep continuity. Let me give you a sense of the stakes with real physiology. Each time your airway collapses, oxygen falls and your brain senses danger. In response, your body surges adrenaline and briefly tightens blood vessels to push oxygen to vital organs. That emergency response is fine once, but 200, 300, 400 times a night? You are micro-traumatizing the lining of your arteries. The inner lining, endothelium, loses some of its ability to relax vessels when needed. That dysfunction over months and years helps plaques grow, helps tiny blood clots stick, and helps small penetrating arteries feeding deep brain structures become fragile. On MRI, we later see white matter hyperintensities, bright spots that correlate with gait slowing, poor attention, and higher stroke risk. You never felt those spots forming, but your pillow position, your oxygen dips, your nighttime surges helped right them. That is why I use strong language in a gentle voice. I want you alive and independent not just next month, but 10 years from now. I can hear the fair question, will changing position tonight erase risk tomorrow? No. Risk isn't a switch, it's a slope. But slopes change direction with small, consistent pushes. If you stop back sleeping, reduce reflux hits, calm your nighttime blood pressure, and treat apnea if present, your brain begins to live in a different chemical soup, less adrenaline, less inflammatory noise, fewer spikes. Over weeks, sleep deepens. Over months, blood pressure patterns improve. Over years, those differences show up as fewer events, better memory, and steadier balance. Your job is not to be perfect, it is to be persistent. Some of you will say, but I've slept on my back for decades. I believe you. Habits are comfortable. So is a slow drift toward harm. The good news is you don't need to become a different person to sleep differently. You need friction, gentle constraints that make the good position easier than the bad one. That's why I like wedges, knee pillows, and the back bumper trick. It's why I like small changes in timing and salt. It's why I want your last caffeine 8 hours before bed and your last alcohol at dinner. None of that requires willpower at 2 a.m. It just requires a small plan at 7 p.m. Another group I don't want to miss are people with atrial fibrillation or a family history of stroke. If your heart rhythm ever flips into AFib, especially at night, you are at higher risk of clots forming in the top chamber and then traveling. Sleep apnea makes AFib more likely. Treating apnea reduces AFib burden. If you're in that camp, position and apnea treatment are not nice-to-haves. They're core parts of your stroke prevention plan alongside whatever your cardiologist prescribes. If you've already had a transient ischemic attack, a mini-stroke, all of this matters even more. Post-event sleep apnea is common and is associated with worse recovery and higher recurrence if untreated. This is one of those places where the brain, the heart, and the airway meet. You can't optimize one and ignore the others. I want to give you a simple way to tell if your position is sabotaging you, even before a sleep study. Ask the person who sleeps near you 2 questions. Do I snore loudest when I'm on my back? And do I stop breathing or gasp in that position? If you sleep alone, use your phone as a night recorder for a few nights. Many free apps will capture snoring and pauses. Pay attention to morning clues, headaches, sore or dry throat, a tongue with indentations along the sides, unrefreshing sleep, brain fog until noon, blood pressure that's higher in the morning. None of these proves apnea or reflux, but together they paint a picture. If the picture looks like you, change position now and book a visit with your clinician to discuss formal evaluation. You deserve answers, not guesses. Let's turn this into a 7-night challenge. Night 1 and 2, you prepare the room and the bed, as I described, and commit to side sleeping with head of bed elevation. No alcohol. Earlier dinner. Gentle nasal hygiene. Saline rinse if you like. A brief warm shower to open passages. Night 3 and 4, you add a short evening walk to nudge blood sugar and stress hormones down. Night 5, you check your blood pressure before bed, and again on waking, log it. Night 6, you repeat the routine and note whether bathroom trips are fewer. Night 7, you review. Snoring reduced? Morning clearer? Blood pressure closer to dipping? If the answer is yes, you keep going. If not, you still change the inputs. Now escalate to formal screening. That's how we behave like scientists in our own lives. Change one variable. Measure. Adjust. For those of you with neck pain who rely on back sleeping to manage it, I get it. Pain wins at 2 a.m. My compromise is elevation plus alignment. A wedge that lifts the torso, a pillow that keeps the neck neutral, and a careful check that your chin isn't falling forward into flexion or tilting back into extension. Both extremes narrow the airway. If you must be on your back, think recliner posture, not flat on the floor. Many patients do well with an adjustable bed that raises the head 20 to 30 degrees, a position that often reduces both snoring and reflux. It's not as protective as side sleeping for positional apnea, but it's a meaningful upgrade from flat. I'm often asked if changing sleep position can really compete with medications in stroke prevention. It's the wrong comparison. The best stroke prevention is layered. Blood pressure controlled, diabetes managed, cholesterol treated when appropriate, smoking stopped, exercise and diet tailored, rhythm monitored, and sleep stabilized. If I convince you to change position tonight, and you're also the person who finally takes evening blood pressure seriously, who closes the kitchen earlier, who respects their CPAP, you didn't pick one tool over another, you built a system. Brains survive because systems work, not because slogans do. Let me close with a sentence I wish someone had said to you years ago. The night is not downtime for your brain, it is treatment time. And treatment can be as simple as gravity used wisely. If you do nothing else after this video, do this. Stop making your airway fight gravity alone on your back. Give your brain side sleeping with good support. Give your esophagus a left tilt if reflux nags you. Give your blood vessels a calm night by avoiding late salt and alcohol. And if you even suspect apnea, get tested and treat it. I have lost count of the patients whose blood pressure normalized and whose thinking sharpened when we finally stopped their airway from collapsing. I have lost count of the spouses who cried with relief when the snoring stopped and the morning anger faded. Every one of those victories started with a choice made at the pillow. If you're still here, you're my kind of patient, curious, and ready to act. Tonight is not about fear. It's about leverage. A small change in how you sleep pays your brain interest every single night. And while I can't promise that one position change erases risk, I can promise this. The brain you wake up with a year from now will reflect the nights you gave it between now and then. Give it air. Give it calm. Give it the side. That's how we keep you thinking clearly, walking steadily, and telling the people you love the same story you told me today. I decided to protect my brain, and I started with my pillow. For those who want the science behind the coaching, here are the pillars I've woven into this advice. Obstructive sleep apnea increases stroke risk even after accounting for traditional factors, and positional apnea, worse on the back, lengthens and increases breathing pauses. Side sleeping and head of bed elevation reduce airway collapse for many, and positional therapy is a recognized tool in mild disease and as an adjunct in others. Nighttime blood pressure patterns predict events. Being a riser is a hazard, and peak nighttime values matter. Reflux worsens supine and improves on the left side. Fewer nocturnal arousals mean fewer stress surges. Alcohol and excess evening salt push nighttime blood pressure and airway tone the wrong way, and recent guidance urges stricter limits for cardiovascular protection. These aren't fads, they're the quiet physiology you live in every night, and they're why the harmless way you set your pillow can be anything but harmless for a brain you want to keep. Now put this into practice. Reshape the bed. Choose the side. Elevate the head. Calm the late-day salt and alcohol. Respect your CPAP if it's been prescribed. If you snore like a motorboat on your back and you stop breathing in that position, Don't wait for a scare to push you into action. Book the sleep evaluation. Your future brain will thank you for what you did quietly tonight.